Welcome back. We're picking up our discussion on Canadian socialized healthcare with Dr. Shawn Whatley. Dr. Whatley, before we cut for break, we were talking about this concept of rationing healthcare and the people who control the levers who decide who gets what when. Expand on that, because I think this is an interesting discussion that has to happen. People seem to think that it's the doctors who decide, but there's actually, in fact, a bigger body that sort of decides.
Yeah, I'm glad you even mentioned that, because in the court case out in BC, they actually blamed the doctors for mismanaging wait lists. So to be clear, there's a whole bunch of people involved in little different parts of rationing the care that you get, whether it's budget setting or clinic time or OR time. But it speaks to a deeper point. And I think this is crucial for people to understand. There are three main differences between the people who provide care and the people who regulate or manage the overall system of care. And those three things are, number one, doctors, nurses, tax clinicians, they're focused on providing care for you. Mm-hmm. So you come in, you need care. We're focused on trying to get you the care you need. We put priority on you if you're really, really sick, and we'll pour all our resources in our whole department just into you if you're sick and dying. And finally, we focus on you as an individual. So provision, priority, and individuals. Whereas the state has to have a different set of objectives. So the state thinks about distributing care and regulating care. So they're thinking more at a higher level. They're thinking about equality of care, not priority. They want an equal product distributed equally across the whole country. And finally, they think at a population level. Now, the Ministry of Health and the civil servants would love doctors to think more about populations and less about individuals. But patients still want their doctors and their nurses and their technicians and physiotherapists and on and on. They want people to focus on them as individuals. So right. I argue that there's a fundamental conflict between the system and the people who are trying to provide care within that system.
So to me, you said it's a fundamental conflict. I think it sets it, the system is set up for that. You said clinicians on one hand and those administrators, if you will, on the other. How do we resolve that conflict? Is that even a possibility within our healthcare system?
Great question. And that's the question for my next book. What are some practical ways to resolve this? I think the first step is putting that patient right back in the center. And what do patients need? For example, patients need a relationship. Whenever you're in trouble, whether it's legal trouble, accounting trouble, or you have car trouble, you want to know someone. You want to know a mechanic or an accountant or a lawyer or a physician in this case, or a nurse or a therapist. And so we have a vast disparity in the quality and access to care based on whether or not a patient can form a relationship quickly, whether or not they have inside connections inside the system. So we could start with a refocus on relationships. What are we doing to compromise relationships? What are we doing to support strong clinical relationships? And there are dozens of other ideas I could go from there, but I just give you that one.
You have to save it for your next book.
Yeah, that's right.
Okay, there's a concept you also brought up, or that exists, called privileged patients. And I know it's sort of a taboo thing, and maybe I'll let you do the explaining on it, because I can suggest what it is about, but you're obviously the expert on this. But when I hear this, it makes me a little bit, well, I feel very badly, because I thought, well, if we're talking about an equitable system where we all should have access to the same treatments, and why are there privileged patients? And especially in recent times when we hear about, politicians who are making these lockdown rules for one group of people, but then flouting them in the other, it sets up an interior conflict for me. So please explain what privileged patients are, and is this an actual problem?
It's a huge problem. And so you've actually asked about three questions together. Is it a problem? Who does it? How do we know it happens? How does it happen? And so I'll try to answer the first one quickly. I know we only have a few minutes. In 1998, they did a study on this, asking 800 physicians and hospital executives, are you even aware that this exists? Is this a thing, right? Privileged access. And over 50% of the physicians said, yes, at some point I have been asked and have helped provide privileged access to patients. Over, I believe, 30% of hospital executives admitted to the same. And so, in fact, in Ontario, they passed a law called Protecting the Future of Medicare Act, in which they made it illegal and they assigned a fine to anyone caught helping patients jump the queue. And the reason it happens is because whenever you have a really tightly regulated system with a whole bunch of rules and wait lists, you create a system that's ripe to incentivize people to get around those wait lists and figure out how they can get to the head of the line. And unfortunately, it's often the people who maintain these lists who are exactly the ones that seek ways to get to the front when they are sick.
We're going to cut to commercial, but when we return, I want you to continue your train of thought here.